Well, good morning. I am really delighted to welcome everyone here to a very important discussion about COVID vaccines and their place in each of our health and in our ability to contain the COVID-19 pandemic. So thank you for joining us today for this very important discussion. I'd like to start by saying how really grateful I am for the tremendous work everybody on this call has done this past year, and that I know we're going to keep going. Thanks to you for your resilience, and because of it, our school has been able to operate exceptionally in these most challenging times. I'm grateful to each of you individually for your work and your commitment to public health. And I am very pleased to be able to say what I've said many times, which is that the school's leadership has been and remains committed to a number of things every single day, to preserving jobs, to preserving health, and to preserving and escalating the mission of this great school of public health throughout this pandemic and beyond. We're committed to protecting each of you and all of us, protecting families, protecting communities, and public health leadership has been guiding the university and the university's approaches. And today we really want to focus on our individual and collective approaches within the Mailman School. And that has to do, of course, with the fact that we have two vaccines. One is our non-pharmacologic vaccine, of classic public health approaches, which we need to keep going, of wearing masks, facial coverings, I should cover my nose as well as my mouth, of physical distancing to diminish the likelihood of contagion, and of course, hand washing and keeping all surfaces clean. The second vaccine is the new COVID-19 vaccination, and that's the topic of today's discussion. We are immensely lucky and because the vaccine, building on 20 years of research on coronaviruses generally, has enabled the production of vaccines with unprecedentedly great effectiveness. And we'd like to have two of our preeminent leaders to explain to you the information on the vaccinations and to be able to answer your many questions about their development, the distribution, how to get them, and any concerns that you have. We want to be sure that you, our very important staff, have an opportunity to ask our leaders these questions directly. So as you know, Dr. Wafa El-Sadr and Dr. Jeff Shaman, who are leading our discussions today, have been at the forefront in keeping our local and global communities safe during the pandemic. And today they're each going to provide a brief presentation of their work and then take questions. They've received questions that were submitted in advance, but you can ask live ones by typing them in the Q&A box at the bottom of your screen. So I look forward to seeing you in person as this virus abates, but for the moment, I'm grateful to be on Zoom together. I'm grateful for our partnership in meeting our mission, and I'm grateful for the opportunity to share the knowledge of what these vaccines deliver and what they can mean. In the meantime, I wish you and your families good health, and now I'd like to turn this over to Dr. El-Sadr. Wafa.
And thank you very much, Dean Freed, the pleasure. And thank you all for being here today. Really looking forward to our discussion, and thank you for all the terrific questions that were submitted prior to this webinar. Let me share screen. And hopefully, Lauren, you can see full screen, right?
Yes.
Okay, terrific. So the focus today will be on vaccines, but before I get to vaccines, I thought it would be really good to talk a bit about where we're at in terms of the epidemic in very brief terms. And as you are well aware, all of you, is that the epidemic continues to grow unabated, with now more than 105 million confirmed cases globally, and more than 2.2 million reported deaths. And when we look at the by region, in terms of the regions that are reporting the most numbers of cases, we know that the Americas, North and South America, have been leading, followed by the European region, then Southeast Asia, Eastern Mediterranean, Africa, and lastly, the Western Pacific. And I think what you note from this map here, upper right-hand corner, is that no country in the world has been spared from this novel coronavirus. And the top 5 countries in terms of largest numbers of reported cases of COVID-19 include the United States, India, Brazil, UK, and Russia. And the US has been leading for many, many months in terms of reporting the largest numbers of cases. Now, what's been happening in New York City very quickly is that New York City is now experiencing a second surge in the numbers of cases. We had the first surge that occurred last year in March and April and May. And then we had really a very low reported numbers of cases throughout last summer and early fall, with the beginning of an increase in this second surge here about the beginning of November or so, with an increasing numbers of cases reported in the city, now at about average about 5,000 newly reported daily cases in New York City. So we appear to be plateauing at this high plateau, and what we really should be trying to do and need to do is to decrease these daily numbers of cases so we can go down again to a very low numbers of cases in our city. Similarly, we're now, in terms of the testing, about 9% or so, between 8 and 9% of people who get tested in New York City are positive. And contrast that with last July and August, September, it was less than 1%. So we clearly have a second surge in New York City, and that's why we're talking about what we need to do now to contain the spread of this virus. And as you can see in this map, there's great diversity across different neighborhoods and boroughs in New York City in terms of, again, of the burden of COVID-19 within our own city. So let's talk about vaccines. I mean, the good news is to determine large news is that we have for full use in this country, we have 2 now vaccines that are for full use, approved for full use in this country. There are several vaccines that are moving along this trajectory, and hopefully we will hear about some of these vaccines, the new vaccines, over the next several weeks. Now, one of the most common questions I get asked is, how were these vaccines developed so quickly? And people get very nervous about this. And I want to share with you why these vaccines were developed quickly. And first and most importantly is that the vaccine developers actually had a head start. The technologies on which these vaccines were based already existed. It wasn't starting them de novo, creating something that had never been done before. The technology existed, so that the researchers had already a head start. In addition, assure everybody that there were no shortcuts that were taken in the research process, as I showed you in the prior slide. All of these vaccines went through the traditional phase 1 small studies, phase 2 a bit larger studies, and then phase 3 larger kinds of studies in the traditional way that research is done. Most importantly, and probably this is the one factor that allowed for this rapid development of these vaccines, is that usually you do these studies, and then after you finish your phase 3 study and you find something that works and is safe, then the companies start building the factories and then producing the vaccine vials. What happened in the context of COVID-19 is that actually these factories were built and the manufacturing was started when very early on, when there was a hint that a vaccine looked promising. With then the purpose that if it worked, well and good, we'd be ahead of the game, already have manufactured the vaccine. And if it doesn't work, then these vials would essentially would be wasted. So that's good news. So this was done simultaneously, not sequentially. Another factor is that there's enormous interest, of course, in development of these vaccines, and therefore people were eagerly volunteering for these studies. Rather than in usual research studies, researchers have to work very hard to find people who are interested in these studies. People came and eagerly wanted to participate in these studies, and obviously there were resources to do these studies. Importantly is that all of the data from these studies were not reviewed by the companies themselves, but they were reviewed by independent bodies. And these independent bodies included the researchers, but also included as well community members and ethicists, including independent bodies at both the CDC and the Food and Drug Administration. And then lastly, there's existing process for approval that already existed at the FDA, so did not need to reinvent the wheel. So I tell people actually, the experience with the COVID-19 vaccines, they should inspire us to say the opposite, like why do vaccines take so long in the traditional way? We should be developing vaccines in such rapid manner. Now to focus on the two vaccines that are available in the United States, the Pfizer-BioNTech and the Moderna vaccines. And as I mentioned, several other vaccines are moving along quite rapidly. And you've heard even last week, data from the Oxford AstraZeneca vaccine, the Sputnik V vaccine from Russia, Johnson & Johnson Janssen vaccine, Novavax, and other vaccines, all of them moving along well. The good news is that these two vaccines work remarkably well. 95% efficacy of the Pfizer-BioNTech vaccine and 94% efficacy. This is way beyond our wildest dreams. Scientists would have been glad if we had a 70%, 60%, 70% efficacy. So this is fantastic. It means that these vaccines are highly protective against, importantly, symptomatic COVID-19 disease. And also importantly, the safety studies showed that there were no serious side effects and no major concerns. Most of the side effects were mild to moderate, and most of them were right at the injection site and lasted for a day or two. And as you probably are aware, both of these vaccines require 2 doses, day 1, day 21 for this vaccine, and day 1, day 28 for the Moderna vaccine. Now, an important concept that I want to just run by, because that causes sometimes a lot of confusion. The vaccines we have, all of the vaccines that have been studied, they have been focused on prevention of symptomatic disease, preventing people from coming down with illness, with sickness, with symptoms due to this virus. So that's what they've been focused on. And these studies demonstrated, as I showed you, that these vaccines work really well in preventing people from getting sick with this virus. We don't know. We also know that with this virus, lots of people can be asymptomatic, meaning that they have the virus and they potentially can be infectious, infecting other people, but they have absolutely no symptoms. They don't know if they're infected at all, but nonetheless, they can transmit this to somebody else. And we don't know. It remains unclear whether these vaccines prevent these asymptomatic infections. That's important, and I'm sure that Jeff will touch on this. So, of course, the good news is that the vaccines, we know for sure, prevent people from getting sick and getting severe illness from COVID-19. Now, do the vaccines work for all groups? I hear this question all the time. And the good news, again, and this is one example from the Moderna vaccine, but the others, the Pfizer one is similar. They seem to, again, the data show us that they work overall rather well, 94%, as I showed before. But if you look by age group and whether people had comorbidities, meaning other illnesses or not, whether they were men or women, whether, again, comorbidities or not, and whether they were white or communities of color, this vaccine and the Pfizer vaccine seem to work really well across all of these groups. So that's very important. Another question we get asked is it necessary for me to get the 2 doses? And the answer is yes. And the reason for this is because the first dose of the vaccine essentially primes. It's like you're painting a wall and you prime the wall before you put on the real paint. So the first dose is important. But what we know from some of the studies is that after that first dose, what you can see is at day 21 here for the Pfizer vaccine is the level of protective antibodies in the bloodstream seem to be quite similar to what's been seen in the group that did not get the vaccine, that got the placebo. And it's only after that second dose that we start seeing this protective response and higher levels of antibodies. So we strongly recommend that people should get the priming first dose and then the boost by the second dose. Now, what are the most common side effects? And I think that, again, the story is reassuring. Obviously, anything, any drug or any vaccine, will have side effects in some people, not in a lot of people, not in some, in more than others. But the good news is that with the vaccines we have thus far, is that most of the side effects, as I mentioned, have been mild to moderate. Most of them have been local at the site of injection, a bit of pain or tenderness when you push, or redness or swelling. Some people have developed systemic side effects, again, less common, also not severe, like headache or fatigue or fever. And what's been shown is younger people, because they have a stronger immune system, tend to have a little bit more of these side effects than older individuals whose immune system is a little bit fatigued with age. And then also what's been shown with some vaccines is sometimes the local reaction may be a little bit more with the second injection than the first injection. But nonetheless, the good news is that there have been no severe no severe reactions, and most of the reactions have been mild to moderate. There have been a few people who've had what we call severe allergic reactions, and that means that they had a history of severe allergy, what we call anaphylaxis. And such individuals, again, have to be observed very carefully after they get vaccinated. They have to be observed for half an hour, while everyone else can be observed for 15 minutes. And the reason for the half an hour is most of these severe reactions occur usually early after vaccination, within half an hour. So just to summarize, that the side effects from vaccines occur usually within a few days after vaccination. The side effects of vaccines are very different from side effects from other medications, where they could happen early or late. But what we know from other vaccines, the side effects tend to happen early. Again, I mentioned that no serious side effects, but of course we know that as you give these vaccines to larger and larger numbers of people, certainly a small number may develop some severe side effects, and that's why I'll tell you about how we're monitoring for side effects. However, again, the risk we know from something like influenza vaccine, it can cause rare complications, but the risk is extremely small compared to the millions and millions of people who receive influenza vaccines every year. And there are two systems to monitor for vaccine safety in this country. One of them is a system where people who get vaccinated, you can download this app, CDC app called vSafe. And this one you monitor every day after the vaccination, report if you have any side effects. And then there's a passive surveillance system that's also available. Anyone can report side effects through this system as well. Now, quickly, who should be prioritized for vaccination? Think of two categories. What we want is to get people, the earliest people to get vaccinated are the people who are at highest risk for getting infected. And the other group we really need to focus on vaccinating are the group that are at highest risk of complications of COVID-19. So either people at high risk for infection or at high risk for complications of COVID-19. So high risk of infection, healthcare workers, essential workers, people in congregate settings like prisons and homeless shelters. And then the people at highest risk for getting complications and getting very sick and hospitalized with COVID-19 are older individuals, people with other comorbidities, as I mentioned here, and pregnant women. So in New York City now, currently the eligible groups fall into these two categories. Those at highest risk for infection, like healthcare workers and resident staff of nursing homes, and also those and first responders and so on, and those at highest risk for severe illness, like older individuals, fall into this category. And then there are other groups that will come on board as we saturate these very important people that need to be vaccinated first, then other groups would then become eligible down the line. Now, one of the most important things has been who is getting vaccinated in New York City. And this has been an issue, you've heard about this in the media. So when you look at the cases rates in New York City, you'll see that Hispanic, Latinx populations, the rates are higher than amongst African Americans and whites in terms of getting COVID-19. If you look at hospitalizations and death rates, you will see that when you look at those, though, it's both Hispanics and Latinx, as well as African Americans that are more likely to be hospitalized, meaning to get sicker with COVID-19. And unfortunately, they're also more likely to die as well from COVID-19. So we are now, all of us are monitoring what's happening in the city. And just to show you here, for example, if you focus amongst Blacks, is that 22% of the city population are Black African American, while only in yellow here, only about 11% of people who've been vaccinated thus far have been Black African Americans. And similarly, 29% of the city's population are Latinx, and only 15%, on the other hand, of the people who've been vaccinated have been Latinx. So we need to think very carefully about how do we get the vaccines to the people most likely to be affected by COVID-19. So we're in a race. The race is between the virus and the vaccines. And in order to achieve the benefits of a vaccine, to achieve the impact in terms of controlling this pandemic, we need to achieve two things. We need to do two things. We need to have vaccines that work well. And fortunately, the vaccines we have now work really well. The efficacy in these studies was very high, as I mentioned to you all. But the other challenge is, how do we get sufficient uptake? How do we get sufficient coverage with these vaccines? Because you need to achieve sufficient coverage using very effective, highly efficacious vaccines in order to achieve the desired impact. So we have one challenge ahead of us, is how do we achieve uptake and coverage, particularly amongst the people at highest risk of infection in particular. And this is the goal, is to achieve what we call population, or some people call herd immunity. And ultimately the goal is to achieve, to have about 70 to 85% of people would need to be immune in order for us to be able to achieve what's called population or herd immunity. And ultimately, you can see the easiest ways to look in this figure. All these individuals in blue, they're all susceptible, so you have infection spreading widely between them. Then as you, for example, you vaccinate individuals, and now they're in green, the people who are vaccinated, you're able to transmit to fewer numbers of individuals. And then, of course, as you achieve higher rates of vaccination and protection amongst people, all the people in green here, then this can then enable, even though there's some few people who remain without vaccination, for example, without protective immunity, you're able to nonetheless prevent spread of the virus. So ultimately, to get to uptake, increase uptake, and is we need to try to get individuals to move along the spectrum from people who are either have doubts about the vaccines or are anti-vaxxers to an extreme end of this spectrum, and then to get people who have questions, who are more or less along the spectrum here, or they have a wait and see approach. We need to understand the questions that people have and try to answer those questions honestly and directly, so that we can move people to the point where they are actually ready and willing to get vaccinated. And this means that we have to provide information, but more than this also, we have to be able to recruit and engage the communities themselves, identify champions within those communities, develop narratives and so on by people from the communities themselves, so that we're able to then achieve as much as possible high uptake and high coverage, so we can get to population immunity. Now, just to touch on these new virus variants that you've heard about, there are lots of variants that are circling around, but the media has been focusing on the United Kingdom, one identified in the UK, the one identified first in South Africa, the one in Brazil. But viruses, just keep in mind, viruses, as they multiply, as they spread from one person to the other, they mutate, they develop new variants. So the only way to stop new variants is to really be able to stop transmission from one person to the next. And the worry is that the variants, these new variants, may learn how to outsmart our vaccines or learn how to outsmart our treatments. And the good news is, thus far, is the new variants do not affect any of the COVID-19 tests, so that's good news. They may affect how well vaccines or other treatments work, but nonetheless, keep in mind that we know how to create new vaccines. The manufacture, the design of new vaccines for this virus is not complicated, it's not time consuming, And hopefully that as new variants appear and as they spread, there'll be also new vaccines that will be developed to tackle these new variants. So I end here by reminding everyone that even after people get vaccinated, it's really important to keep in mind that we have to continue to do all the preventive measures. What we do the day before we get vaccinated and the day after we get vaccinated is exactly the same thing. And why is that so? It's because, of course, protection from vaccines is not immediate. And I showed you what happens after a first dose, for example. And no vaccine is 100% effective. The duration of protection, we don't know as of yet. We don't know if these vaccines prevent infection, and therefore somebody could potentially get infected with the virus, and if they're not wearing a mask, they can unknowingly transmit it to somebody else. So everybody has to continue to mask and to distance and so on. And then lastly, we know that these new virus variants may also compromise to some extent the efficacy of the vaccines we have at this point in time. So I guess I end with that. For the foreseeable future, please, please, please keep in mind that this is the foundation of everything that we need to do and to continue to do for the foreseeable future, so we can gain the benefits of these vaccines, and also so that we can stop the emergence of new variants as well. I'll stop here and stop sharing. Thank you very much. And I'll hand it over to Jeff.
Yes, thank you. So thank you for a great presentation, Wafa. Thank you for having me. I'm going to share my screen, and I'm going to talk a little bit about some of the issues at population scale and get to that very issue that Wafa was touching on at the end there. The first thing I want to talk to you about is the fact that this virus is problematic and it's pernicious because it shares characteristics that are common with common colds. And specifically, it causes a lot of infections where the person infected really never knows they have the virus, but that they're still contagious. So my own group did a project called the Virome of Manhattan, where unlike the typical surveillance that's done for respiratory diseases, where we document infections of things like flu or respiratory syncytial virus or rhinovirus, because people seek clinical attention for it, and then they may be swabbed, and then we know that that person has the flu or RSV or rhinovirus. We don't ever actually go out into communities typically and surveillance for specific agents to see how much of them are actually around. But we actually did this in a project. And when we did that, what we found is there are many, many more infections out there than you get a sense of if you just look at the passive surveillance system, just those people who are seeking clinical attention. So the subclinical infections actually greatly outnumber the clinical infections. And this allows these viruses to get around. It actually is the reason that they persist in our communities. If we think about what happens in the wintertime cold and flu season, typically before the pandemic, most people, if they get a little sore throat or they get a little body ache, what do? They do nothing. They go to work, they go to school, they go out shopping. If they have a trip or a vacation to go on, they'll get on an airplane. And what are they doing when they do that? They're sharing the virus. They're taking this agent with which they're contagious and they're bringing it into these new communities and they're sharing it broadly. And by doing so, these viruses persist. What we were able to see is that less than a quarter of infections from something even as severe as the flu are actually medically attended. And most are asymptomatic by any definition of asymptomatic. This is the property that allows these things to get around epidemiologically and allow them to continually affect us, along with some other issues such as the variants that arise from them. So when we saw this virus emerge and saw how quickly it was spreading within Wuhan, from its epicenter throughout China, and then hopping on airplanes and going to Thailand and South Korea and the US and Japan, we immediately suspected there are a lot of people who are getting this virus who probably are unknowingly spreading it. They just are not aware that they have the virus and they're sharing it with other people. They're going about their normal routine because they're not laid up. They're either shedding the virus before they have symptoms, or they're never manifesting with enough symptoms that they ever bother to go see a doctor. So as part of the research that we've done in our group, we've actually documented that. We've actually quantified what those rates were. We did it first for China, and we found that only 1 in 7 infections prior to the lockdown that took place over a year ago on January 23rd, 2020 in China were documented. And that those undocumented infections, which are mostly people who are asymptomatic or mild, were still contagious. Per person, they were only about half as contagious as a person who might be clinically attended, but because there were so many more of them, they could spread the virus around. As a matter of fact, we were able to test this in a computer simulation model and show that if you didn't have these undocumented infections, the outbreak in China would have been 1/5 as large. 80% of the documented cases would have gone away. And it's these undocumented infections, people unknowingly spreading the virus, that set up chains of transmission. And somewhere along the chain, somebody will have a severe reaction that will require clinical attention and hospitalization and put them at risk of death. But not everyone does. So most of what's going on with this virus is silent, it's stealthy, and it's undetected. Now, we took that same process that we did and we actually applied it to the United States. And it's something that we've been using to try to understand what the characteristics are in the US, how the virus is spreading, make projections of what's coming our way over the next 4 to 6 weeks, and to do a lot of analyses about how you might better control it, how vaccines are going to affect us, how non-pharmaceutical interventions, the mask wearing, the social distancing, the restriction of mass gatherings, how those are impacting the continuum of this pandemic, how it progresses. The first thing that we were able to see is we did the same sort of estimates for the US for the early phase, and we found it was just like what we saw in China. In fact, there were fewer documented cases relative to total infections. And the reason was we weren't testing very much. We didn't have the tests widely available, and we were restricting their use. We've subsequently looked at this over the entire reach of 2020 and all the way up to the end of January now. We perform with our models what's called an inference, where we fit, which is what you see in the upper left here, the model to the cases, and you can see that nationally and for the New York metropolitan area in the inset. And you can see that we're able to make the model fit well what actually happened with cases. We can actually look at the total number of cases and see at different time points and locations, do they match seroassays, which are serosurveillance, to see who has developed antibodies, who has evidence of a prior infection. And this actually validates the system as well. Now, the thing that's in the circle there shows you that ascertainment rate. What fraction of total infections are being confirmed? And you can see both nationally and for the New York metropolitan area, as well as the other metro areas there, that over time, and those numbers mean months, the ascertainment rate has risen, meaning more of the infections have been documented. And this lines up with the fact that we've had a greater abundance of testing, it's more available, it's free, people are going and getting tested, and people are more sensitive that if they have any sort of symptoms, maybe they should get tested. They want to find out. So we're seeing a rise in it, but you can see that when you get to the end of last year, to December 2020, it's still a little bit under 25%. It's under 0.25, meaning only 1 in 4 infections is being documented. And that holds for New York metro area as well. So we still have a lot of this unknowing infection out there, this undocumented infection, and people who are contagious when they're undocumented, who potentially can put other people at risk and support the transmission of this virus in the community. This is why it is so critical that everybody wears masks and social distance, because most people who are contagious are unaware that they are contagious. As I said, even people who become symptomatic shed the virus and are contagious, it's estimated for 2 to 3 days before their symptoms even appear. That's one of the critical public health points. And that's why, for instance, masks are so important, because even if you don't feel anything, you could be contagious. And the mask is particularly effective at preventing a person who's infectious from spreading it out into the environment and infecting other persons. All right, so what are we doing with vaccination? Well, we have these vaccines, as Wafa elucidated here. You know, we have 2 very highly effective vaccines from Pfizer and Moderna with 90% efficacy after the second dose, 1 week after the second dose of each. And of course, there's sort of this enthusiasm and joy that we all experience because it's sort of a light at the end of the tunnel, right? We have something that we're going to be able to give to people so that they can get the vaccine before they get the virus. and it's going to protect them, and we're going to be able to move into a post-pandemic period where we move back to normal. The problem, of course, is that to get this vaccine effect, we need to produce it, distribute it, and administer it to people. And we need to do it to a lot of people. We're a country of 330 million people. Right now, we estimate a little over a third of people in the United States have been infected with this virus thus far. All right, greatly in excess of the 27 million you hear, because so many of the people who are infected were never documented, right? But the problem is we have a lot of arms to get this vaccine in. And if we relax the non-pharmaceutical interventions early, more people are going to get infected than before they receive the virus. Well, excuse me, before they receive the vaccine. The critical message here is that we have to continue with these non-pharmaceutical interventions, because not only all those reasons that Wafaa laid out at the individual level, at a population level, we will allow a resurgence of the virus if we relax our non-pharmaceutical interventions before enough people are vaccinated. And given the rates of production, distribution, and administration, it is going to be many months before enough people are vaccinated that we're going to have 70 to 85% coverage of the population. So just to show you, what we have here are different scenarios where we deployed the vaccine at a fixed rate, and that's shown at the top, and we then relax the NPIs in different ways. There's a null scenario, S0, where we didn't administer the vaccine, and it shows you what fraction of the population would be infected if nobody wore a mask or socially distanced anymore and no vaccine were delivered. And you can see it's above 0.4, which means more than 40% of the population of the US that has yet to be infected will be infected with the virus. If we relax the NPIs and distribute the vaccine at this schedule that you can see here, we're still almost at the same level. It's still 40% of the population that gets infected. The only way to really curb it and prevent people from infection and the risk of hospitalization and death is to continue with the non-pharmaceutical interventions for the foreseeable future. That slows it down. Now, this research was put in the New York Times last week, and they have some great graphics to illustrate it. And it shows you what we projected if current restrictions, the current level of NPIs in the country were maintained until late July while the vaccine's being rolled out. And you can see the dashed line shows you the curve that follows. But it says then what happens if the restrictions on non-pharmaceutical interventions, if they were completely lifted February 1st. Do you see how there's a bump there? There are 29 million additional infections that take place as the vaccine's getting rolled out because we relaxed those interventions and we didn't hold fast. Here's another graphic that they put together from the results that we had there, and they show you different things. If we held in place until late July, this is the total number of infections. Now, this is infections, not cases. You can divide that by about 4.5 to get the total number of cases, okay? We already estimate that we have about 120 million infections thus far. So we're talking 38 million additional infections as a vaccine rolls out in this projection. But if we were to strengthen the NPIs, if we were to do even better, we would reduce that number quite a bit, almost 20 million. If we were to relax, as I showed, it gets worse. 29 million more infections, more people in the hospital, more people dying from this. There's some more graphics here. I'm not going to belabor it, but those just show the different scenarios, and I think you get the general idea. The main message is that we have to actually hold on to these non-pharmaceutical interventions for the foreseeable future until we can vaccinate enough people and we really quash the virus down. We don't have a definitive timeline of that, but given current rates of production and administration, it's going to be many months. So my encouragement is to psychologically steel ourselves that it's not going to be till summer that we're really going to be talking realistically about some sort of return to normal and a lack of the social distancing measures that we see. It may be great, something may happen. The Johnson & Johnson vaccine may come out on the market. We may produce, increase, and boost production and distribution and not have problems with the variants that are on the horizon. And we may be able to do it sooner. It may be longer also if we have unforeseen problems crop up. So I think we just have to steel ourselves and understand this. Now, I also threw together a very quick slide based on one of the questions that I saw in advance, which was, what is the effect of rapid testing versus a PCR test? And the answer is, we actually don't know fully. And the reason is, people, when they get infected, they have a shedding level that comes out. You get it, acquire the virus, it starts replicating in your body, producing many copies of itself, and you start to shed that virus out into the environment. The level of shedding follows some time course that you see moving from left to right there, and it peaks at some level in the middle. All right. So people over the course of infection, on average, they'll start shedding more and more and more. They'll peak and then it drops off. May not look exactly like the curve, but this generally gives you the idea. Now, somewhere along that line, you're shedding enough that you're going to be contagious. You're putting enough virus out there that you could possibly infect somebody. Where that level is, we don't know. We just don't know that. We don't know that for COVID. We don't know that for any respiratory virus. So we have these two different types of testings kits, PCR based and then these rapid tests. The PCR test is more sensitive. Now, it is possible that the PCR test level of detection is below that green line, which means it tests you and finds infections before a person is actually contagious. It's also possible that the rapid test is not sensitive enough and only identifies you after you've surpassed the level of contagiousness. But the truth is, because we don't know where that green line is, it could move around. It could be up there, and it might be that the rapid tests are just as valuable as the PCR tests. So unfortunately, we don't really know a good answer to that. I'll stop there, and I think we can take some questions at this point. So Wafa.
I've been answering the questions in the Q&A, but I don't know if we have a way of unmuting people. I don't know. Maybe Lauren can tell us, or people can continue to.
Well, we did have some questions beforehand. Maybe should we start going through some of those?
Yes, we can do those. Some of them have been answered already, but let's see. I'm going to start from the top and hold on.
How about indoor dining is opening again?
Yeah, indoor dining. I mean, I'm not a fan of indoor dining. For a couple of reasons is that I don't think it's an essential activity. I think it's more important, I think, to get kids to school than for people to enjoy indoor dining. I think the other issue is, of course, people, when they eat and drink, they remove their masks, and they're usually not distanced as well when they're sitting together. They may be distanced from another table, but they're not distanced among themselves. So I think I feel like allowing indoor dining at a time when we're experiencing a surge in the city is premature. I don't know what you think, Jeff.
I completely agree. I think indoor dining is not the way to go right now. I think, look, anytime you bring people together in close quarters, that's the people sitting at the table, the waiter coming in and out your way, and even the people in the rest of the room, you're providing additional opportunities for transmission of the virus that wouldn't be there if you weren't sitting at a table in an indoor space for
without a mask
period of time. So, look, it's important that we support restaurants. I think takeout is a fine way to go. It minimizes your exposure opportunity and it contributes to the economy, of course.
Especially at this point in time. With
yes.
This. The other question is, do the different strains differ in terms of symptomatology, pathogenesis? Unclear. I mean, my sense, the data seem to say that these new, some of these new variants may be more transmissible, more infectious from more likely to spread from one person to others. But I think it's unclear as to whether they cause more severe illness or different kinds of symptoms. We don't have firm data on this as of yet. There are anecdotal reports of maybe affecting more younger people than older people with more severe illness, but I have not seen at least good evidence to support that they cause more severe illness. Jeff?
That's exactly in line with what I've seen. I would completely agree with that. There's really good evidence that the UK variant is more transmissible, that it binds better and enters our cells better, that people shed more of it, and that it moves more rapidly from person to person. But in terms of its virulence, how intense the outcomes are, whether you're more likely to be symptomatic or hospitalized, I haven't seen strong evidence one way or another at this point.
Maybe another question, I'll bump that to you, Jeff, is how do you determine R0 and RT?
So there are a number of ways of doing it. They're all.
Can you explain what it is?
Sure. So you've probably heard a lot of these things of R0, RT. R naught is called the basic reproduction number, and what it signifies is the number of infections an infectious person would cause over the entire duration of their infection if you plunk them down into a fully susceptible population. Now, you can't think of it as this immutable fixed number, because the R naught in a place like New York City, where we have subways and public transportation that's used, and if you go out and you live there, you may run across hundreds, if not thousands of people in a day who you potentially could give the virus to or receive the virus to, whereas some rural county out in West Texas, and you're really encountering very few people, there's going to be a different R naught. Now, that's an upper bound on how transmissible the virus is in a given community, and it sets the herd immunity threshold in an idealized sense as well. All the non-pharmaceutical interventions that we're doing right now suppress that R naught, which is a good thing. It reduces the number of people a person can infect if plunked into a fully susceptible population. And that's why we advocate them so strongly. That influences what we then call the RT. That's what it is when you've imposed those changes because you're wearing masks and socially distancing and not dining indoors. That's the thing that is RT, but that's transient. The minute you relax all that stuff, it can go right back up to the R naught number, which means the virus will accelerate through the community. So when I talked about the need to continue those non-pharmaceutical interventions, the mask wearing, et cetera, it's because if we relax that stuff, we're going to go from an RT of maybe 1.4 right now in New York City to one that might be more like 3. And the virus is going to accelerate. More people are going to get infected before they receive the vaccine.
Okay. There's another one that I'm going to tackle, which is when will vaccine testing start on children, and how will that look? The studies are ongoing already, looking at children down to the age of 12. These studies have been in the field; they're ongoing. The expectation is that we'll have some results by the summer. So stay tuned. So that's good news to see what we'll find. Another question, and maybe that one I'll send to you, Jeff, is again, I think we discussed, both of us mentioned this, but please discuss what is known about whether those who've been vaccinated can still be vectors of transmission. And as I mentioned, the vaccines we have not shown with sufficient data that actually they prevent somebody from getting infected and remaining without symptoms, right?
Yeah.
And if you are infected, don't have symptoms, you can transmit, as Jeff said.
Yeah.
This is what happens. This is a feature of this virus. So I think that's that's the reason why we say that even people who get vaccinated, they should continue to wear masks, because they may be infected without symptoms and can then transmit to others. So they need to continue to wear masks. Jeff, you want to add to that?
Yeah, so, with a vaccine, there are 3 principal endpoints that you might have. One is that the vaccine stops infection altogether. Second would be that it stops transmission onward. And a third would be that it stops symptomatic infection. For both the Pfizer and Moderna, and really all the vaccines, yeah, what they judge is that last one, symptomatic infection. That's what they can evaluate. That's the most easily observable. So when they say 95% efficacy, that means at reducing symptomatic infection. Now, of course, that's what we want more than anything. We want to keep people out of the hospital and prevent people from dying from this virus.
Mm-hmm.
But what we don't know is really what its effects on those other 2 endpoints. There's some preliminary data from a smaller subset from Moderna that it does reduce asymptomatic infection, which means it reduces transmission. And you could argue also that because people who are symptomatic tend to be more contagious, that by reducing symptomatic infection, you're reducing transmission, but it's not 0. And it's probably not a 95% efficacy. So people getting the vaccine are really being protected against hospitalization and the worst consequences of the disease. But what is actually happening to them acquiring and passing on the virus is less well understood.
Right. Another question that I'll start to tackle is someone who has hesitancy, but who is at a higher risk group. Any suggestions on an approach to help someone have trust in vaccination? I think that's a very common situation, actually, and I think it really depends on why. I mean, I think I encourage people, if they know someone like this, to ask them, what is it that makes them not eager to get vaccinated? Is it that they're lacking some information that we can provide to them? Is it that it really depends on the reason that they're hesitant. So I would say explore. one of the common reasons for people are hesitant, as I mentioned to you, is they say these vaccines were developed too fast. I showed you some of the information, the answers you can give them as to why this vaccine was developed fast. Some people are worried about side effects. You can share with them the information about side effects. Some people say, these vaccines were not studied in people like me. You can tell them who were participants in the studies. And these studies included diverse populations, young and old, different racial ethnic groups, and people with and without these illnesses, these comorbidities. So it really depends on why. And then to, again, try to give people the information as much as possible. And then if they need, again, to try to find someone that they would trust, someone that either in their age group or from their racial ethnic backgrounds who can be a trusted person to try to convince them. I think for someone who's at high risk, I think we should really do our very best to try to convince them that the vaccine is certainly highly recommended to protect them and their health.
Wafa, what would you say about people who are immunocompromised and immunosuppressed?
Yeah, I
What
think
would you
that
advise?
the common question is immune suppression. Some of the studies have included a small number of individuals with HIV, controlled HIV infection, and so that's good. But largely these studies have not included people with cancer on chemotherapy and so on. So we don't know how well the vaccine will work in them because they were not included in those studies. But most people say that because such individuals are at high risk, such high risk for complications of COVID-19 and getting the infection, is that as you weigh the risk benefit, probably after they discuss with their provider, obviously, probably I would err to saying there's a potential benefit, and we know, and therefore probably would opt to get vaccinated. That would be my approach. Another question here, and I'll get that to you, Jeff, is what is your perspective on summer travel, US and abroad?
Yeah, people want to make plans and they want to travel and we want to get back to normal. I think we're all itching to do that. I know I am. But the reality is I think it's premature. I really do. We really don't have a good sense of the time scale of how long this will take. If you're traveling internationally, we really focused on the US context here, and the distribution of the vaccine is highly inequitable and uneven throughout the world right now. So you really also need to pay attention to where you're going in terms of what they've been able to do to deliver vaccine, and have they had access, and have they had compliance and uptake of it. I think within the US, we still run into the same problem. How much coverage will we have? It's a big country. There may be some areas and pockets where there's been a lot of vaccine refusal that may be problematic. We will have to see. So I think my advice, and this is very personal, would be you might want to hold off for a bit.
Yeah, I think it's premature. Hold off. Everybody's watching this very carefully, and also there may be countries where there are restrictions. I know that in my work there are places where you have to quarantine and so on after traveling. So I think it's important to keep that in mind, and it's hard to anticipate what it's going to be like in the summer at this point. Another question is, does receiving the vaccine affect COVID testing? The answer is no. And that's why we recommend that people who receive the vaccine who continue to participate in the Columbia testing program and get tested as appropriate. It does not affect the tests themselves or the testing. So please, if you're sampled and so on, please do go and get tested. Very important. Another question is, what about advice for are there efforts about reaching older people? Yes, there are, and that's exactly the priority groups in New York State, as you're aware, is that now the priority groups, the eligibility include people 65 years and older. So that's the effort now is focused on these groups and try to enable them to get vaccinated. It means we have to overcome, if they're hesitant, overcome their hesitancy, but also we have to make it really easy for them. And that's been part and parcel of the problem. And as you heard about this, is some people have to stay up all night trying to find an appointment for a vaccine. And there are efforts now to try to take the vaccines out to the people. There are pop-up vaccine sites happening that are being situated in churches and communities. There are efforts at helping people make appointments, efforts at using people who speak different languages as well as navigating or escorting people for vaccination. So I think we need to make it easy for people to get vaccinated once they decide they want to be vaccinated. Okay. What about children vaccinating testing going down to 12? What can we expect for younger groups than 12? Can we assume younger kids will be wearing masks and socially distant into the next school year? Jeff, what do you think? This is younger than 12, I assume.
Younger than 12. You know, there's still a lot of debate about this.
Yeah.
You know, it's really a very difficult question to answer because I've seen so much evidence going in both directions, saying that children, particularly under 10, are not really involved in the transmission cycle, are not passing it on. Whereas I've seen other evidence where clearly that did happen. It's actually very confusing out there right now. We have in-person schooling, K through 5, opened up in New York City, I believe. My children are above that, so I can't quite remember. But you know, the reality is, if your children are old enough to wear a mask right now, I think that they should wear a mask right now. What's going to happen in the 21-22 school year is something that we're really going to have to decide over the summer. I mean, hopefully it will be in person. Hopefully we will be in a post-pandemic phase. Hopefully we will be in a position where we're on top of the variants and that school happens in person and we can get back to some semblance of normal education.
Yeah, and I think the other thing is that looking at the data that are available out there, it certainly doesn't look like schools are really the drivers of transmission in a community, and that's based on testing been done in schools and some evidence that shows that transmission from children to adults is not as high as transmission from adults to adults. So anyway, I think. But I agree with Jeff that if a child is old enough to wear a mask, and they should, and also, of course, ventilation in the schools and distancing are very important. What about how much? Yeah, how much is known about post-infection complications? This is, I think, the long haulers. This is a syndrome. So there are now evolving data from a variety of sources, both here and overseas, that some people who've had COVID-19 after the acute period when they have the acute symptoms of COVID-19 appear to have these long-term symptoms. These may be fatigue, they may be headache, they may be poor appetite, they may be specific symptoms like aches and pains or cough and so on. There's research that's ongoing now to try to understand what's going on. Why are they these longer-term effects in some people, not in everybody, but in some people. So we have a lot of questions we don't have the answers to, but I think it highlights the importance of doing all these preventive measures, because COVID-19 is not a benign illness. I mean, people can have very mild symptoms and recover with no problem, but people can have severe illness and have problems, or people can recover but then have these long-term, the long haulers. So we need to take it seriously. Yeah. And try to prevent it. Something here, another question. Timeline for vaccination for people under 65 years of age at Columbia. I just want to tell everybody that the vaccination here is really by New York Presbyterians, NYP. Columbia doesn't have any vaccines at this point. We're hoping that in the future, some of the practices, the Columbia practices, will have vaccines to give out. But all of the vaccination is being done by New York Presbyterian, including here on this campus, as well as in the Armory and so on. And the plan is, I think the question is, once we saturated the groups that need to be vaccinated now, and that's a large group, all of these essential workers, all of the healthcare workers, all of the people 65 and older, I think then the question is going to be, what do you do? What's the group you do next first? Is it people with comorbidities at any age? This means somebody could be 25 years old but have a chronic illness. They have chronic ulcerative colitis or any other serious medical condition. Are we going to go to people with these comorbidities at any age, or are we going to say, no, we're going to go just by anyone less than 65 years of age? I think we'll still need to prioritize. Because keep in mind, again, there's the two principles. You want to get the people at highest risk for infection, but you also want to get the people at highest risk for complications. Okay. Jeff, and what can we do about people who believe in conspiracy theories? How do we get them to, how do we tackle people who believe in conspiracy theories and they, social media perpetuating these? What are your suggestions?
Well, that's a very, very challenging question. We could be here all day on that. This is sort of an information denial, and obviously we have a society right now that's very divided in terms of where it gets its information. We have really two separate ecosystems, if you will, that people populate to find their information, and the inhabitants of each thinks their information is factual and that the others is ludicrous. I happen to think mine is factual, and the evidence I've seen really strongly suggests it, but there are people out there who believe that 450,000 people having died in the United States from this virus is a complete hoax. There are reports of people in the Dakotas who were in the ICU dying from COVID who refused to believe they had the virus and said it's just pneumonia. We've seen all this, and I don't know how we can penetrate this. I'm not as bullish on providing you a simple solution for something that doesn't provide a simple solution. We're very entrenched right now. It's very difficult to make rational arguments when something is really passionately held by an individual. And given the amount of reinforcement there is out there on the web, the internet, chat groups, and through certain media outlets, there's a lot of conspiracy theory out there that promulgates that people seem really able to believe in spite of the evidence out there that's being reported by more trusted sources.
Yeah, I mean, I agree with Jeff. I mean, I wish we had a magic answer. I think I sort of think importantly is, I don't think, I know it's very hard, but I always say take a deep breath. There's no reason to demonize such individuals because that will turn them off completely. Is listen and try to be consistent, providing answers to issues they raise. Try to be a source of information. Also, keep trying to find different sources of information until you might hit on something or somebody who will make it happen, who will just click with them and convince them otherwise. So I think it's never give up. I mean, my mantra in life is never to give up, is don't demonize, keep at it, try and think of other sources of information, people that people trust, and keep at it. And I think trying to do that is not easy, but I think it's very worthwhile. I think we've reached
the end here. So
I'm just going to say a couple of words. I really want to thank everybody who's on this webinar and thank Jeff in particular. But we are available. We're here for you. You can send emails anytime, day or night. I answer emails very promptly if I know the answer, or at least I can find the answer for you. Can send them to Jeff when I don't know the answer.
And Wafa doesn't sleep also. That's the other added benefit.
But we're here for you, so let's continue the conversation. Jeff?
Thanks for having us. And just as Wafa said, I would be happy to answer questions. Just send them my way, and I will get to them as I can, and hopefully within a few hours, and let you know what I'm thinking and try to pass you on to other resources if need be. Everybody be well. Please wear your face masks.
And be careful, and take good care, and stay connected, and stay well. Bye-bye.